Good evening. Thank you for joining us. My name is Sue Hill. I'm one of the Vice Presidents at the Royal College of Surgeons of England. In the real world, I'm a vascular surgeon, and I am one of the board members of CPOC. And the purpose of tonight's webinar is twofold, I suppose. On one hand, it's to introduce CPOC to you, that is the Centre for Perioperative Care, and its second intention is to expand a little bit on perioperative care so that we can look at some of the difficulties that we're all facing during the COVID-19 pandemic. So I'm going to chair this session. With me, I've got two panel members. First one is an anaesthetist, in fact. So David Selwyn works at Sherwood Forest Hospitals. He's the medical director and both an anaesthetist and an intensivist. And he's the clinical director of the Centre for Perioperative Care. Scarlett McNally is one of my colleagues on council at Royal College of Surgeons of England. She's an orthopaedic surgeon, works in Eastbourne, and is one of the deputy directors of CPOC. So I think they've both got short presentations, and we'll go straight into that, and then we'll save some time at the end to take your questions. So David, fire away.
Thank you. Well, good evening, everybody. And so over the next 20 minutes or so, I'm going to give you some background and some context to the Centre for Perioperative Care, some idea of what we're trying to achieve with CPOC, and then I'm going to finish with some considerations relating to the current COVID-19 pandemic. So in terms of the Centre for Perioperative Care, so this was launched just over 12 months ago, and it has a very laudable aim of putting the patient at the centre of a more joined up, a more structured perioperative pathway, and utilising a greater or an enhanced multidisciplinary team-based approach. As with all things, the language is really important, and so it's termed a centre and not a faculty. And it's also termed perioperative care, not medicine, to recognise the truly multidisciplinary approach. So in terms of what have we been doing for those 12 months or so? Well, we've been setting up a lot of structure, a lot of process and governance around this. I would say we've established a high value stakeholder board, and you'll see the representatives on the screen in front of you. And these stakeholders are there to give guidance and to give direction to the centre to ensure that we deliver our aims. And I guess I might just note that I'm really pleased that we've got significant trainee representatives on this group, but I'd also recognise that there's a number of equally valued stakeholders or stakeholder groups who aren't necessarily represented on the board. And I think the challenge to us as we get into the next year is how we're going to harness and utilise the work and the enthusiasm of all of the stakeholders that CPOC represents. So in terms of why have I got involved with CPOC? Well, to some degree it's around the excitement or the art of the possible. And for me, as Sue says, as an intensive care doctor or an anaesthetist, it's around getting into perhaps unconventional areas. So it's around getting into the role of primary care, where the patient first is considering the surgical journey and helping with those decisions. It's also right at the end of a journey, perhaps, with ensuring that the wraparound care that the patients needed once they leave secondary care and go on to rehabilitation is available. And of course, having a background in critical care, optimizing the physiology is clearly important to someone like me. But actually, what else? Well, for me, really important is to truly embed shared decision making when we're discussing the surgical plan procedure with our patients. And I think we pay a lot of lip service to this at the moment, but we really don't do this very well. And hopefully Scarlett will pick up on some of these aims in the next session. What else is there? Well, many of you will work with specialty teams, but again, it's strengthening that, taking that team and ensuring that they're all pulling together and delivering the best possible outcome. And then finally, I think there's a real opportunity with CPOC and the perioperative care to deliver truly transformational change across all 4 nations. So what about matching the NHS long-term aim, the 10-year plan? Well, it does offer the opportunity to meet the triple aim, to improve the patient outcome, the patient experience. It does offer the chance to improve the population of our health, the health of our population. And it does offer the chance for us to be more efficient, to enhance our processes, to get the best possible value that we set up. I'd say that CPOC's not really about reinventing the wheel. It's about building on the excellent work and the grounding that's already taken place, and a significant amount of work is described there. And of course, at the same time, it's about being an agile and responsive organisation so it can respond to changes that may occur and the future that may be sooner than we imagine. And again, rather unusually, perhaps for a frontline clinician, it's the excitement of getting into these areas where we can really add extra value for our patients. We spend all of our time concentrating on that third box across, the clinical care, and probably all concentrating on the quality of that clinical care, which has a relatively modest impact on the overall health outcomes of our population. If we move across towards the left-hand side, towards the health behaviours and then the socio-economic factors, there's the opportunity for us to actually make a much greater impact on the health outcomes of our patients. And this is what we can deliver with a fully joined up, fully functioning perioperative care pathway. And you'll be aware of the phrase making every contact count and trying to encourage behavioural change and encourage the prevention agenda in our patient population. And we recognise that the surgical event is a really powerful stimulus, but how many of you have seen a patient in clinic who comes up with this sort of answer? And actually what we need to do is we truly need to make every contact count. We need to take that motivation and encourage our patients to change themselves, to take some ownership of their health, and with that, some ownership of their potential recovery and outcomes. Many of you will focus primarily on changes to the pathway, and this has been eminently described by many authors. It's not just about that. It's about actually ensuring that you have a team that has a unified voice, that everyone recognises the value of individual members, and the sum of each other's input is greater than the sum of one. And putting the patient right at the centre to deliver the best possible outcome. And whilst I might describe a perioperative pathway in terms of a series of boxes, I want you to take 4 things from this slide. I want you to take that right at the top of the slide is the overarching importance of shared decision making, cutting across everything that we do with our patients. I want you to consider that actually at referral, a surgical option may not be the right option for that patient. It may not be the best thing for them. And so alternative non-operative pathways might be the best journey for this patient. And one of the things that we've not been great at is setting up what those alternative non-operative pathways might be. But we can get better at that. Thirdly, I want you to look right to the right-hand side in terms of the day of the operation, the surgical event. And without recognizing that I'm speaking to a surgical audience, maybe the importance of the surgical stimulus should be comparable to all of the other boxes and the importance of all of the other aspects of the perioperative pathway. And then finally, those arrows where you can truly make a difference and you can influence that patient's journey and influence their health behaviours. And this is our joined up pathway at Sherwood. And really, I think most of us would agree having a motivated, optimised patient who's going to have an improved outcome is a very laudable aim. And how you put together your pathway will differ to some degree, but some of the components are described as there. So in terms of the themes of CPOC, how are we going to concentrate on taking this work forward? Well, we've put 6 key themes. I can't explore all of these, but you'll recognise that many of these will resonate with a lot of the work happening in terms of the change process across the NHS and the long-term plan. If I just think about perhaps the Perioperative Quality Improvement Programme, many of you will have heard of this. This was a laudable project set up in 2016, and in essence, it was trying to discover what might happen to our 10 million patients having operations every year. What are the complications? What does good look like for these patients? And centres that have been recruited into providing data for the PQIP study have shown a 1-day length of stay reduction across the board. If you take 1 million procedures a day, about 350 pounds a night in a hospital, there's Boris's bus just going past the window, just from collecting that data. So these 5 national improvement priorities have been released, and you can see there the perioperative assessment, diabetes, communication, pain management, and enhanced recovery. Just touching on a couple of those, hopefully most of you will agree that getting your patients in the best possible state for surgery is likely to influence the outcome. There's much talk about what the optimum hemoglobin is, and whilst I don't really want to get drawn into that argument, I think that having enough blood is clearly important, and actually you can make a very easy cost improvement program to improve your patients who have their anemia corrected preoperatively. What about diabetes? Another key component. So it's really disappointing that despite all of the work that we've done, still only around 70% of our diabetic patients are getting an HbA1c measurement undertaken preoperatively. Absolutely key to improving the outcome on these patients, and CPOC will work with the diabetes experts and deliver an improved diabetes guideline to help ensure that this is better. And then there's a lot of excitement around the potential opportunities by prehabilitation. And on this graph, most of us come across patients who are on the dotted green line, where they have a complicated recovery and they don't really recover awfully well. But actually, if we can encourage these patients to get fit for surgery, undergo some form of prehabilitation, then you can increase the potential miles in the bank they've got, such that when they have their surgical intervention, their recovery is much better, as described in the blue line. And this has been now demonstrated across a number of different surgical specialties. And of course, there's prehabilitation and there's rehabilitation. And this is work going on in Manchester, looking at a stratified process where we get a number of prehabilitation processes, get the surgical event, get an ERAS recovery, and then rehabilitation afterwards, and look at the outcome on what happens to these patients. You don't have to do it in a big teaching hospital. This is data from the South Tees. Preparing for surgery, the Prep Well project, again, relatively simple, listening to the patients, improving their health outcomes, and actually showing a 40% improvement in their quality of life 12 weeks post-surgery for the cost of £53 a week per patient. And Scarlett's about to talk after me about the importance of exercising and getting fit for surgery and helping our patients tolerate the insult. This is John Abercrombie's slide in terms of the girth data and what happens with our colorectal cancer patients. And you can see that's a scatter graph of length of stay, irrespective of what centre you work. And if we can only streamline and harmonise processes and practices, maybe we stand a chance of moving those dots towards the centre of a funnel pot and having consistent outcomes. So just moving on from those, which I hopefully has stimulated you, what about COVID-19? And what would I say about that? So I guess from my point of view, I'd say it's been the perfect example of a VUCA experience. Some of you will have heard of VUCA, volatile, uncertain, complex, ambiguous. Does that resonate with you in the COVID crisis? This is a term adapted from the military to help them deal with fast-moving, fast-changing, uncertain situations. And if you're going to actually try and navigate your way through this sort of event, you need a different style of leadership. You need different styles of leader, people who are comfortable with ambiguity, people who are comfortable with uncertainty. And that's not something that we're good at as medical professionals. In terms of what I might say about my own organisation, I would say that our medical leaders have massively stepped up and pulled together during the COVID crisis. It's been a real strength that we've been able to take wicked problems to our leadership groups and actually try and find solutions. I'd say the other thing that has happened is that innovation has been dramatic and at pace. I think I've moved my hospital on probably 3 years in the space of a couple of months in terms of what the change we've made to do. We've made whole service changes in the space of hours, not years. And I'm sure you'll recognise much of that. I think from my organisation, we've also changed us from being a digitally able organisation to more to being a digitally willing organisation. An example would be us giving this webinar, which probably wouldn't have happened a year ago. And actually our clinical teams now, instead of me having to push digital solutions to try and drive change, they're now clamouring to pull digital solutions and asking for more to make things different, better, easier. And our patients are adapting to them equally. I think it's really important to recognise how fast things have changed. And whilst I can barely remember last week, trying to remember what our state of PPE, what the recommendations were, what we should do about social distancing, being in the operating theatre in the midst of March is almost impossible. And there's something called hindsight bias, where it's very easy to look back and say, well, I told you all along you should have done it at that time. But in fact, the decisions we made at that time were only as good as the information we had at that time. And it's interesting to reflect on some of the decisions, perhaps that NHS, the government have had to make, and just to be considerate of hindsight bias. And then, of course, there's the new normal. What will it be like? What will our roles be? Will COVID go away? All of those uncertainties that we don't know the answers to. And how those uncertainties and how we harness those and what they'll do for our organisation, what impact. And then finally, I guess the learning I'd say is the consequences. The consequences for us as clinicians, the worry we have for us and our families, coming to work when we don't know what's going to happen, but also the real consequences for our patients and how they feel and what is happening to them and how we're communicating with them. And how we have found it relatively easy to stop the majority of our services, to stop doing what we normally do, but how incredibly difficult it is to actually try and restart things in a structured way, not knowing what is going to happen. And there are lots of different considerations you can have in this, but actually this is a real opportunity for us to look at what has changed and what we want to keep of the new normal and what we don't, and what we changed and what we didn't change and why we didn't change. And many of the colleges are giving advice on how to restart things and to slowly bring back surgery, be that day case surgery or elective surgery, be that the surgical colleges, be that the anaesthetic colleges, or even the American colleges. All of these have slightly different takes on what they recommend and suggest. And of course, it all depends on the uncertainty of where we are and what will happen with further waves. This is data from my ED department, and what it shows is that the normal activity compared to the same time last year, and then the impact of what's happened with lockdown when we drop down to about 60% of our activity. And this is patients who attend ED majors and ED resus. These aren't people who are worried well. These are sick people. And then the impact of when lockdown has been released. Where has that other 40% of patients gone? Where are they? What is the harm that is happening to them? Who is looking after them? And again, data from my hospital looking at our 52-week waits, our cancer pathways. We used to have very few cancer waits over a year, but that is now on an exponential rise. And I really worry about that harm that is going on in that group of patients because it's completely invisible at present. And this paper looked at the possible harm associated with stalling cancer, colorectal cancer, suggesting around 1,400 patients would have an attributable death. But we need to balance that against the risk to restarting surgery. And this was the original paper, the Wuhan paper, suggesting that there was a very high mortality with unsuspected COVID and surgery. And you'll recognize this data from the recent Lancet publication from the COVID surge group. And the bit on this paper that worries me is right on the far right-hand side, the elective patients, suggesting that actually they have an increased mortality rate of around 18% on top of the baseline mortality. So we're getting some national guidance on how to restart surgery and what we need to do in the processes. And I have to say it's fiendishly complicated, and many of you will have experienced this. We are finding our way through this. Nobody knows the right answer. We are all trying to do our best, and there's national guidance, but we're trying to find local solutions across the patch, what works with us, and you will have a series of those. And this paper was published yesterday, trying to manage some of the theatre processes. I, like you, get tremendously frustrated about our ability to do actually any operating with the precautions we have to take now and the processes that we go through with our surgical patients. And maybe the time has come to reconsider some of our AGPs as described in this paper. Finally, it's what do we talk to our patients about? How do we explain that risk, that shared decision making, allow them to make that conscious decision about whether surgery is the correct thing for them. Elective surgery, it may not be. And this is something that we're trying to prompt by explaining the changes that you might see. And of course, keeping our patients notified. There's a number of FAQs being released by the COVID surge group as well. This is just something that we developed, giving some guidance on what you might expect. So I'll stop there. This is my hospital. It's a really expensive PFI, but if anyone wants to come and work there, drop me an email. Thank you.
Okay, thanks, Dave. That's very interesting. But I'll save questions till the end, if you don't mind, and we'll move directly on to Scarlett, please.
Hi, thank you. So, thank you. I'd just like to talk really about how perioperative care can help surgery, particularly during and after this crisis, change the health for everyone. Just to say, I've got no conflicts of interest, but I'm paid for a session a week for my time with the Centre for Perioperative Care. So I think there are some big wins, one around the prevention of complications of surgery, something about risk and decision making, and about team working and pathway redesign. And just to mention about smoking, people who stop smoking can halve their complications. Even very short amounts of time of stopping smoking can reduce the risk And it's the complications that add to more problems, obviously, with patients after the event. This is a World Health Organization paper that came out just recently saying the reduction in morbidity was around 19% even after only 4 weeks, and continued at 19% further every subsequent week. I've been involved with work on by how much exercise can change people's health, particularly in terms of prevention, and it's hugely important for preventing diseases such as dementia, type 2 diabetes, and also treatment of those diseases so that complications are fewer. Now, these are all the comorbidities that people have been hearing about now with COVID-19, and the public is really ready to think about different ways of managing health. And that's the bulletin paper that's got all is the latest one on that. Just to say the size of the issue, there's 1 million people on the waiting list for trauma and orthopaedics, ENT and urology, which are specialties when most people are older and most have 2 or 3 or 4 comorbidities. So this is the population that surgeons are very familiar with dealing with. And really, people talk about lifestyle choice, but your lifestyle choices depend predominantly on your social situation. That report, Exercise, the Miracle Cure, came out of the Health Inequalities Group of the Academy of Medical Royal Colleges. It depends on people's environments, what their family and friends think of as normal, and what other things they are able to do in their situation. And for things like smoking and road traffic collisions, it's required legislation and regulation in order to change behaviours, which is really about changing what people accept as normal and the normal culture. So it's really the 3 big things to reduce complications: smoking, exercise and nutrition. And it's not just about heart and lung fitness and tissue oxygenation. It has effects on inflammation and on metabolic factors as well. And the other factors of alcohol, mental health, medication review and psychological preparedness are also important as well. But it's the 3 big things we should be working on. And surgeons in general don't get involved in this for several reasons. We probably don't really know the scale of the benefits, but we particularly don't want to jeopardize the doctor-patient relationship by feeling like we're shaming people or that it's been done already or tried already. And particularly, we probably think other people do it better, and we are absolutely right in that. Other people do it far better, but unless we talk about it, it doesn't get seen as important or valued. So you can learn how to do motivational interviewing. It's not just telling people what they should do. And the best course, I think, is the 1-minute course from movingmedicine.ac.uk, and you can learn how to involve a motivational interviewing technique into your ordinary consultation practice. The Making Every Contact Count training is freely available to anyone with an nhs.net email address on the elearningforhealth.org.uk website, and I recommend that all the staff, particularly the reception staff, the managerial staff, admin staff, to understand that they are allowed to have this discussion conversation with patients, or to carry it on if someone else has started it. And it's basically, you've got to ask and then assess and then advise. You've got to ask permission to have that conversation and see what the patient think would work for them or what they've tried. Going back to exercise, it can reduce complications by up to 50%. We're doing a bit of work at the Centre for Perioperative Care around collating better evidence, but it's good and it works. We've done some work with Macmillan about prehab for cancer, and again, it's very good for getting patients motivated and with fewer complications. I'm going to go back one, apologies. Just like to say some of it's about giving permission. Now, this is a personal slide. I'm just saying that I was very ill last year and my GP told me to try going for a walk every day. The consultant told me the heart's a muscle, you've got to use it. And actually I found those 2 things very powerful to almost give me permission to go back to doing what I wanted to do. And that's me on an exercise bike at the Macmillan Centre. The only person who's ever used that exercise bike I've seen in the whole time I've been there. But it's a start, and that's when I couldn't climb a flight of stairs. So it's not just putting the exercise bikes in there, it's making people want them. And I think all these people that are being told to self-isolate before their surgery should be told, get an exercise bike, treadmill or rowing machine, because that's where you'll get the best result from your surgery. Fruit, vegetables and protein help with wound healing, and we need to talk about maybe smaller portions. For some people, reducing their carbohydrates is better for their diabetes than the normal low-calorie diets on offer, but we need to be aware of it and help people. There are risk prediction tools in terms of people having more major surgery. You can pop all the patient characteristics into one of those, and they will come out with the risk prediction. And then you can think about the fixed risks and the modifiable risks. And you need to know this to discuss it with the patient, because it comes down to the patient expectations and outcomes. More papers are publishing patient-reported outcome measures. We know around 10 to 15% of operations have a complication, but also around 14% of patients report regret after surgery. So it's really the question of picking winners with patients. The other thing is some surgery isn't as good as we think. This is shoulder arthroscopic subacromial decompression. This came out in 2017, a paper suggesting that it wasn't actually any better than not doing an operation, and that's a statement from the British Elbow and Shoulder Surgery Society and the British Orthopaedic Association. So the other thing is some of these things around helping the patients who we're not operating on. So all those people on waiting lists, there is something else they can do. It's not that they are being fobbed off by not having an operation. If we've absolutely at this time got nothing we can offer them in terms of surgery. So this has come out from all these 7 bodies about how you can manage your bone, joint or muscle pain. From csp.org.uk is the best site I think to find it on, but it's on all the others like BOA as well. As Dave mentioned, the risks if someone contracts COVID post-op or has it during the operation unknown are quite high, and it's reporting a 24% mortality or 51% pulmonary complications of people who have general anaesthetics for elective surgery who have COVID-19, although in fact not everyone has been tested, so perhaps it's overestimating, but the risks are there, they're very real, and they will reduce massively the number of people who want surgery, and we need to have this discussion with. So patients need information. There's information on the Royal College of Surgeons of England website and many other websites, particularly in specialty associations. And the pink one is from Centre for Perioperative Care, Fitter, Better, Sooner for every patient anywhere having an operation, how to get the best possible result with reduced complications. The other kind of shared decision-making thing we need to do with patients is to get them to be to feel they want to ask questions, particularly this Brown approach. What are the benefits? What are the risks? What are the alternatives? And what if I do nothing? And the patients need to come armed with that conversation rather than really being told what to do or expecting to be told what to do. And that's part of the Choosing Wisely initiative that is quite closely linked with the shared decision making. Another personal anecdote, I'm afraid. I accompanied a very elderly relative to the follow-up breast cancer clinic where she was advised to have a mastectomy, and she's got the kind of dementia where had she had the surgery she'd have woken up every day since wondering what had happened to her, being angry and possibly being paranoid. And a couple of years down the line she's doing very well on the letrozole tablets every day, going out for a walk every day, and still doesn't know she's got breast cancer or doesn't remember even when she's told. So it's a different way of managing the whole patient. Now, I know we all think we do it, we do this all the time, but actually it's something that actually we could all do a little bit better, or we see other people around us that don't do it quite as well and maybe could do it a bit better. It's not only about within primary care and give the problem to the surgeons when it almost certainly needs an operation. We should really get involved in the triage decisions that are going on throughout the pathway. If it's done just through the management of services, patients may very well interpret it as rationing. And that paper is Magic, the Making Good Decisions in Collaboration network, which is working on training for shared decision making. And again, we've all changed our consenting process following the Montgomery ruling, particularly around what that particular patient would attach significance to. Also, just to say, perioperative care is surgical care. This is an extract from the JCST syllabus of what we expect the successful people coming through core surgery to be able to do and to have learnt and practice. Similarly, this is an extract from Getting It Right First Time. Reversible risk factors really should be addressed to improve care, and that makes better care, more efficient care, and better outcomes. And this is just to say it's also cheaper. The little grey dots are patients, and the area of the shape is the amount of money spent. And 7% of patients in the acute system are responsible for half of hospital costs. And those are mostly people who've had a series of complications. So anything we can do to reduce those complications is good. Just a little word about teamwork. The invited review mechanism is a service that the Royal College of Surgeons of England provide for hospital of a trust where there's a problem with the surgical service. And in the last 100 reviews they found a problem with teamwork in 76 of them, particularly with the team not actually meeting together and therefore not developing or changing practice or going through their own data on quality assuring. And often there were either no practices that were agreed, or they didn't follow an agreed procedure when a protocol did exist, and that was a source of problems with the service. The Academy of Medical Royal Colleges have just brought out a document a couple of weeks ago on how to run multi-professional teams well, because it's not easy. Everyone's got a different background, and the key things are understanding your own skills and somebody else's unique skills, but also understanding what they do, so you can take on a little bit of that. For example, health promotion, you could take on a little bit and then recommend somebody who does it better, for example. But the team need to meet regularly and use their own data, valuing all the team members, and treat that as a normal way of working. We need to change pathways. I've talked about risk scoring and getting the results back at the right time so that patients aren't getting cancelled for surgery or aren't having the opportunity to change and improve things before they get there. And we need to communicate risks. The paper on the bottom is just to remind me to talk about the POTS programme, because elective patients can benefit from the pathway approach as well, with a proactive care for older people approach. So using the skills of the geriatricians and others to get something that looks like a pathway for the inevitable people that are coming in with emergency problems who haven't had time to prepare, as it were. Now, there are opportunities for better health and better perioperative care after the pandemic, which you could put into kind of 4 categories. One is about ring fencing of beds for surgery and the access to critical care beds. At the moment, the critical care bed base are expanded. It would be nice to keep that while we're waiting, so we've got some availability should there be a second wave. We could have that for patients that might otherwise be cancelled if there wasn't a critical care bed available. Similarly, we need surgical beds to be vacant sometimes in order to have an area ring fenced, so that patients can move through that freely, and that fits in with the COVID light wards that are trying to be created. There's been a much better understanding with patients and the public about risk and about prevention, and we need to use that and move forward to make everybody's health a little bit better. And there's something about team working, and then virtual communication, as Dave was saying, has improved how we do business. But it's not just how we interact with patients and deal with patient records and have those to our fingertips when we're trying to assess a patient, but it's also team meetings where people might otherwise not attend because they couldn't travel to the meeting. So I've put some more details of those 4 things, and particularly if you're trying to go through change in the NHS, it's better to have everybody involved, the whole team being allowed to contribute, understanding the data, understanding the reasons. And I think that works better probably with team meetings together that people attend, they're not having to travel, rather than in the past it's only been the medical leaders who've been able to get to meetings to make decisions. And I put in a little win about reduced pollution and more active travel, because that's a very good way of improving how much exercise people get in the general population. So just to summarize, really, the same things that reduce complications are the things that help better health. It's around smoking, nutrition, daily exercise. And then just bear in mind that alcohol and drugs, mental health, medication review and deprescribing, and psychological preparedness for surgery. Just saying, I know I've spoken very fast, but it's a wide-ranging audience. Different people pick up different things. This is the Royal College of Surgeons of England website. This will be available in the resources section once it's been archived in a couple of days. I'm also highlighting the search box if you want to look up that consent or any of our amazing work that we've done before. Just put something in, have a look around, and to highlight the unconscious bias work that we've done a lot of input for over the last few years is back on the front page if that is of interest at this time. So that's it. There's also lots more information, particularly for patients, on the Centre for Perioperative Care, cpoc.org.uk website. So thank you very much.
Thank you both. I've actually got some questions myself, but I'll resist the urge for the moment because I presume our audience might want to have a go. Lucy, have you got any questions?
Apologies, my mute was on. And we do. So a question for David. Is it possible to share the evidence for the percentage weighting of various factors determining surgical outcomes that you showed?
Just say that again, percentage weighting of surgical outcomes?
Of the various factors determining surgical outcomes that you showed.
Oh yes, of course.
Slides.
Well, my understanding is that all of these slides will be made available to anyone who's taking part in this, so you'll have those. Yeah, of course. Yeah, and as doctors, it's the bit that we just don't have sight of, perhaps, and we get a bit focused on our wonder drug or treatment and forget the simple things that Scarlett's been talking about.
There's a huge amount of feedback, positive feedback about the webinar from all parts of the world. So someone from Iraq has said, thanks for hosting, really interesting. Another person saying this is really appealing. But I'll move on to some questions if I may. So does this mean we'll be cautious in offering major surgery for benign diseases, say, anterior reflux surgery, is that right? Will there be an increased role of will there be an increased role of CEPX testing?
Okay, so CPEX testing is a way of it's a preoperative test or a way of assessing people's physiological reserve or anaerobic threshold, and there's a tremendous amount of data on the value of CPEX. It's another test. I think what we're going to find in this COVID crisis, and I don't know what Scarlett and Sue think, but I think we're going to bring things back relatively slowly because it's just so difficult. It's so difficult for us to develop these pathways and actually to try and make them COVID protected. People call them green pathways or whatever. We can't remove that risk. We can only minimize that risk. And whilst we know that the circulating COVID infection in the population is relatively low at the moment, we also know that it's about 20 or 30 times higher within the healthcare organization. So we are the vectors currently of where COVID is being spread, and so trying to ensure that actually we've got those processes in place so we can have that shared decision-making discussion with our patients and say it's really safe to do this is very difficult. And for that reason, I think many of the patients for elective procedures will be saying, actually, thanks very much, but I'll just hang on.
If I could comment on that slightly, I absolutely agree that the figures we've got so far for post-operative COVID infections and the complication rate and the mortality rate if you end up needing to be intubated and ventilated post-surgery and you have a COVID infection are so high that I think anybody carrying out benign elective surgery outside of a completely green unit is taking a lot of risks with the patient's health, and it really is going to be where shared decision making and full candour comes in. Patients have got to understand that at present there's a massive risk if they do catch a nosocomial COVID infection from one of us. I don't know if you agree with that, Scarlett.
Yeah, I'm afraid so. But it's something patients need to know and need to understand. You know, there's people with very severe arthritis who are prepared to take that risk and have a joint replacement, but there are other people that just want to want to wait a bit and see if things settle down, but it's going to be months. As Dave's saying, it's difficult creating the COVID light or green areas are very difficult, particularly with staff moving back and forth, and particularly with needing to have the access to critical care or post-op should the patient require it. So you don't want to have people off-site too much.
Having said all of that, Sue and Scarlett, our experience during this crisis, and recognizing that that was a study and there's some limitations of that study, but during this crisis, in terms of the patients we've continued obviously with our emergency surgery, and we've continued with urgent cancer surgery to some degree, and touch wood, the nosocomial COVID acquisition has been relatively low.
Sorry, I'm stopping the questions. Please ask the next question, Lucy.
No problem. So is it worth considering intensivists attending post-op clinic to see how high-risk patients can benefit from surgery?
So I think when you design your perioperative pathway, you make it up with the people that you need, and I wouldn't be prescriptive about that. I think you get the best people you can to make the best decision, and if that is if you think for that particular patient, that particular operation, you need some critical care input, then that's absolutely fine.
I think anaesthetist needs to be involved, particularly in the higher risk cases, pathways, absolutely, and the preoperative nurses and the physios and all those. You need everyone involved, even if you don't need them very often once the pathway's up and running.
Thanks.
Thank you. So someone else is saying they agree with what the panel's saying, and that wider determinants of health are very significant. Should we share our budget for surgery with mental health services for more benefits for our patients? In a PQIP data, 40% of patients have anxiety or depression 6 months after surgery.
Yeah, it's fascinating. So it's really interesting talking to the I didn't dwell on the pediatric side. Obviously the pediatric workload is around 20% of the surgical workload, and the take from pediatricians is really very different on the perioperative pathway. They feel that actually all of their patients should go through a form of perioperative pathway, because their patients who have repeated procedures, I think about 80% get anxiety and get psychological problems with that. And so actually, if you can prepare them properly the first time that you do it, and you can minimize all of that, you have a massive effect on that patient's whole surgical interface for the a number of times, because they usually come back time and time again for operations.
Can I come in on that as well?
Sorry.
No, thank you. The problem is you've got whatever 120 billion pounds for the NHS budget, and I agree mental health should have more money, but what you can't do is move it out of surgery and into mental health, because if you've got the system set up how it is, people who need operations need operations. What you need to do is to change the system so that people don't expect operations, if you see what I mean, not take the money away and then actually put some of our surgeons in the position of arguing and lobbying for surgery to be maintained, because that's the hallmark of a civilized society. You get some condition, you can get the best possible care, and you will get the NHS to fix it and sort it for you, and that's why we need surgery, and that's what we'd expect for us and for all of our family. But if we as surgeons, and anaesthetists listening and whoever else, but if we can explain that surgery isn't the best for some people, they'll take it from us, whereas they wouldn't take it quite so well from the politicians. So that's what I feel. We need to explain, do the shared decision making, do the discussion, discuss the alternatives. And actually, I hate to harp on, I don't hate to harp on about exercise, but people who do exercise every day actually feel better. It's about well-being, it's about mental health. and reduces depression 30%. It's not just the cardiovascular fitness, it does other stuff for people's health. So and Mind and other organizations have come out recommending exercise as a treatment for some mental health problems or an adjunct. So we just need to slightly change the way we do business and think of what health is.
And
Can
I didn't. Sorry.
Sorry.
Do you want to go, Sue?
Only very briefly. So I was going to make a comment about your presentation, particularly David, because what you're talking about here is a joined-up health service. So a lot of the work that CPOC is talking about and Scarlett's alluding to is what we traditionally think of as primary care, community care, public health, mental health. You're looking at the whole patient in his or her whole environment. And what I was going to say is it's a huge ask for CPOC. This probably should have been an initiative that came out of the NHS and was properly funded. Do you have any comments to make on that?
So entirely. So I was going to follow up with the comment Scarlett made about mental health. We have just had a perfect example of how poorly we've designed our healthcare system in terms of we've divided it into arbitrary barriers. And what I mean by that is what's happened with our social care and our care homes with the COVID crisis. In terms of trying to change the system, we need to get rid of terms like primary care, secondary care, social care. We need to just call it care, because that's all the patient is interested in. The patient is not interested in these handovers, it's not my problem, it's someone else's problem, or you go into the community and someone else pays for it. All of those arguments we spend our life doing, they're not interested in it. We need to design a system that has joined up care and wraps that care around the patient. That would be a fantastic achievement, and I think this is part of the way of driving this. And there is now the recognition, and you'll have seen that in the various briefings, that actually the health service has to change. So we have the powerful change moment potentially, and we need to harness this. We've never had the opportunity like this for 20, 30 years to perhaps make some of that change that needs doing across the health system.
I agree. Can we go on to the next question, Lucy?
Sure. So someone's just agreed and said we should be working as one clinical community.
All right.
Okay. So what role do we have in arguing for more systematic change? 70% of patients on critical care are overweight or obese. Should we be demanding a comprehensive obesity strategy?
Oh, well, obesity is one of my pet hates. And actually, if you look at the mortality figures for COVID, as you know, obesity is certainly a really serious risk factor. I do think we've allowed obesity to become the norm, and we really need to actually stand up as medics and say that it isn't. Scarlett, do you have a view?
Yeah, and again, it's very linked to social deprivation. And the problem is there have already been some obesity reports, and they don't get followed, or people don't think it's important, but it is. And again, it comes down to exercise and nutrition. There's a little bit of discussion about whether it's the low carb, the low calorie, low fat approach, or for some people the low carbohydrate approach actually works better. But we do need to have the conversation, to talk about junk food, to talk about sugar, to talk about portion size. We need to have the discussion, and it's to do with advertising and product placement and companies that are supported. But it is incredibly important, and every day's nutrition matters, and we need to get that message out as a group of doctors. But I think obesity is
social inequality, as you say, deprivation and education. So the obesity issue is a huge political issue, which we can talk about, but we're probably not going to solve. I live in parts of the UK that has a particularly high level of obesity, I'm afraid, and people calibrate their views as to what's normal by what's around them. Anyway, I'll get off my soapbox. Carry on.
Yeah, there's a lot of work going on. It's a separate field of work, and I recommend it. It's very important.
And again, I think one of the things that will come out of this COVID crisis is that a recognition that we have shied away from public health and we haven't invested in public health appropriately, and actually that will change. And having those conversations and that prevention agenda has something we've got to task. I think it's 50% of all 5-year-olds or 3-year-olds are now clinically obese, and that is a tsunami that is going to swamp the health service unless we tackle that. The problem with public health agenda is it's such a long burn. So as you can imagine, investing money, people want to see a return on their investment in a year or 2 years. With public health, you're talking 10 years, 20 years. But you look at COVID, you look at people, the fact we've just conducted the best socio-economic experiment on whether hand washing works, and it seems to, and you know, public health will become much more prominent as a result of this.
Can I just add, public health measures don't need to be a long burn. If you get patients, if patients can get fit enough to walk after their operation, then they don't need to spend quite so long in hospital. You can change things quite quickly.
Lucy, any
Should
more?
we just do one more? Yeah, there's plenty, but I don't think we're going to get to many more. So I don't know if the panel know the answer to this, but will the protocol for elective surgery in paediatrics be different from adults?
It's easier to make a green zone in most paediatric units. That's the only comment I would make. It's easier to make a green COVID light area. So possibly you might be able to start elective surgery a little bit sooner. Don't know if you, what do you think, Scarlett? I don't do any paediatric.
No, I mean, the only paediatric work my unit's really involved in is emergency fractures, which still come in, and it is useful to have the more green areas, and these are cases you just have to get on with. So I don't know of what's happening nationally in terms of planned pathways.
David, do you have any final comment?
No, I haven't seen the paediatric pathway. I showed you the adult proposal. I haven't seen the paediatric one. I wouldn't expect it to be massively different, to be honest with you.
Very similar. It's just they tend to have less COVID they've had less COVID in paediatric units, of course, by nature of their age and so forth. And so I think it's easier to have clean environments. So it might get going a little bit quicker. Okay, well, I'd like to thank everybody for participating. I'd particularly like to thank David and Scarlett for their presentations and all the work they've put into it. And Lucy, thank you for fielding questions. And thank you for our listeners. And I'd just like to draw your attention to next week's webinar, which is Parenthood and the Pandemic. I think I might watch that, see what I was doing wrong without a pandemic. Okay, good night. Thanks very much. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.